responsive and playing with your emotions and all. So when we record this brain activity, it is called as electroencephalogram, electroencephalogram. So it is EEG. This is just equivalent to the ECG, that is electrocardiogram of the heart. So what happened, there are different kinds of waves which we used to see in the normal EEG, right? There are alpha waves, there are beta waves, there are theta wave and the delta waves. Alpha waves are the one when we are awake. These are alpha activity. It is 8 to 13 hertz, means waves are forming by 8 waves in 1 second or 13 waves in the 1 second. This is the frequency of this alpha rhythm. This is usually present when we are awake but with the eye open closed. When we open the eyes, this rhythm disappears. These are the beta waves. Beta means fast. These are more faster than the alpha waves. Whenever you are hyperactive, your eyes are open, you are doing something, so you are in beta mood, you are in faster mood. So their frequency is more than 13 hertz. These are the normal waves which are present in the brain. Now these are the two fast waves, right? The alpha rhythm and the beta rhythm, right? Now when we go into the early stages of sleep, or when someone go into the deep coma or so on, then the two other waves appear normally. One is called as theta. The frequency is 4 to 8 hertz. Hertz means the number of waves which you can count in 1 second, right? So the theta wave is 4 to 8, and the much slower waves are delta waves, which are present in which frequency is 4. These are the normal waves. But the theta and delta waves are usually not found except until and unless patient is in deep sleep or they are comatose. So these are the delta waves. This lower frequency waves, where we find them in very young children, because their brain are growing till the age of 5 years. Their myelination has not been done properly, and during sleep. Sometimes patients who come to us with encephalopathy, means altered level of consciousness or in the drowsiness, we find the delta waves in them also. So what are the abnormal waves? If we talk about these are normal, then what are the abnormal? Abnormal epileptic discharges are polyspikes. You don't need to go into and learn in the detail, but at least you should know the name of normal and abnormal, and you must have an idea that what is the frequency and what all. What are the normal abnormal waves? These are polyspikes and spike and wave discharges, burst suppression discharges, 3 hertz spikes and waves discharges, right? So what are the basically indication of these electroencephalogram? Why we do? For example, if someone come to us and with a complaint of that this child is become suddenly altered, drowsy, this child has a history of falls, and during that this child has, or some person has tonic posturing, means his body becomes stiff, and there is frothing from mouth, sometimes urinary incontinence or the tongue bite, then you think, okay, fine, the history is more likely towards the epileptic seizure activity, right? So whenever you are suspecting someone with the history of epilepsy, then you will go for the electroencephalogram, so you can see that whether there are normal waves or abnormal waves. Abnormal waves are the one which I have told you on the previous slide, that is spike, polyspike, spike and waves, 3 hertz spikes and waves, or burst suppression. These all are the abnormal waves which we can find in epileptic patients. Now what happened, if you think that okay fine, this is an epilepsy and there are the seizure activity, then you have to classify the seizure disorders. As you know, seizure can be generalized tonic-clonic, focal, myoclonic, absence and all. So you have to classify the seizure disorder. So for example, in generalized seizure activity, you will find what? You will find generalized spike and waves pattern. In case of absence seizures, what you will do, you will get 3 hertz spike and wave discharges, right? And in case of myoclonic epilepsy, you will get polyspike wave pattern. In cases of hypoxia, that is brain damage due to low oxygen, you will get burst suppression. In cases of CJD, that is Creutzfeldt-Jakob disease, you will again get burst suppression or triphasic waves. In cases of metabolic causes of drowsiness, that is due to either electrolyte imbalance, hypoglycemia, liver involvement, or the renal involvement, you will get uh, triphasic waves, which are in the metabolic disorder. Now, how will you do? You will do for the assessment and prognosis of the seizures. Means if someone is coming to you with a myoclonic epilepsy, means that this patient will suffer from that kind of epilepsy lifelong. Or sometime myoclonic encephalopathies, they are the inherited disorders and they do not resolve. So this is the prognosis that you will tell the family that this child continue to have a seizures for whole life. And sometime inherited neurological disorders can present with various type of seizure, not a single pattern. So there is a very bizarre kind of pattern with the mixed polyspican waves, generalized spican waves. Sometimes we get the absence type of discharges on the EEG as well. So we know that this type of seizures will continue for the whole life. So this is the prognosis of that seizures. Now, how will you help in the diagnosis of some diseases? For example, in cases of herpes simplex encephalitis, you know, it involves the herpes simplex encephalitis has predilection to involve the temporal lobe. In your lectures on the CNS infection, you will came to know this. So in cases of herpes simplex encephalitis, you will get the epileptic discharges localized towards the temporal lobe, because this epileptic recording is scattered over the whole brain, that is frontal lobe, parietal lobe, temporal lobe, right? So you will get the specific findings on the over the temporal lobes, which are usually localized, means one-sided, not both-sided, which are called as PLADs, that is periodic localized epileptiform discharges. Now, in cases of CJD, I have told you that you will get triphasic waves. And SSPE, this is again the complication of measles. This is one of the form of encephalopathy which is not treatable, and patient keep deteriorating mentally and physically, and they become bed bound. So you can diagnose this as well on the basis of EEG, and they have a burst suppression pattern on the EEG in cases of subacute sclerosing parencephalitis. So if you find this, or in the cases of CJD, you can predict the prognosis that this condition keep on and it will not be treatable, and eventually the patient become bedbound or they can lose their life. Now, what are the other uses of EEG? You have to evaluate for altered level of consciousness. For example, if someone come to you with sudden altered level of consciousness, but there is no witness available who can comment that why this happened, or they do not witness any seizure activity, or fit activity, then what you do, you will perform the EEG. If EEG is normal, means there is no electrical activity is going on the brain, then the patient is unconscious due to some cause. You have to go for the further investigation or neuroimaging, right? Okay, response to the drugs. How will we see, especially if someone come to us with the status epilepticus? Sometimes what happened that clinically the patient seizures stop after giving the anti-epileptic drugs in the form of IV, but instead they do not regain consciousness. So what you do, you perform the electroencephalogram recording. And in 50% of the cases, those who do not respond to the anti-epileptic drugs, when you perform the EEG, you will see there is electrical activities going on. Then you say that this is a non-convulsive seizure. Non-convulsive means apparently body is not showing the signs of seizure activity, but in the brain, seizures are continuous going on. So you will see that whether this is a subclinical activity or what. And then sometime you have to treat the patient, and you have to assess for the response of drug as well, right? If EEG is normal, then you can stop the drug after certain time period. So you can think, okay, so this is the time that we have to stop the drug, because we do not give anti-epileptic for the whole life. Now, the second test is cerebrospinal fluid analysis. I have already told you this is a fluid which is running on around the brain, the spinal cord, subarachnoid space and all, and it protects our brain from the trauma, because we move million and billion times in a day, and our brain floats in that fluid, and it protects it from the hitting skull and getting the traumatized. So what is the CSF analysis? This is usually performed at the level of second or third lumbar vertebrae between the space, or space between the third and the fourth lumbar vertebrae. Why? Because we know the spinal cord usually terminate normally at the level of L1 or L2 vertebra in adults. So below that level, there is no spinal cord, only nerve and CSF, which is called as chorda equina, right? So when we puncture these levels, second, third space or between third, the needle do not puncture the spinal cord, right? So the injury to the spinal cord is minimized by puncturing at these levels, right? So how the normal CSF look like? Normal CSF is colorless, do not color. It has few cells, less than 5, which are lymphocytes. Now, these are the normal things which we see in the CSF, and when some diseases occur, we compare that how these things change. So you must remember normal CSF is colorless, number 1. Number 2, cell count is very low, less than 5 lymphocytes. Sugar is 2/3 of the serum glucose. So whenever you perform the lumbar puncture to do the CSF analysis, you measure the serum CSF and the serum glucose and the CSF glucose simultaneously. So normal, the serum glucose is 2/3 of the CSF glucose is normal, the 2/3 of the serum glucose, and proteins are normally up to 45 milligram per deciliter. So whenever some disease happen, infections, trauma, or any other thing, the parameters, the color, the cell count, the sugar, the proteins, they all become changed, right? Now, when we puncture the CSF, it come out with the some pressure, right? So the pressure of normal CSF is 180 to 200 millimeter of water. It's not the mercury, okay? So must remember, this is measured in the millimeter of water. In some diseases or any kind of disease which can lead to raised intracranial pressure, this pressure starts rising, okay? Now, what further studies we can do? We do for the gram staining and cultures in cases of bacterial infections. Gram staining help us to differentiate between gram positive and gram negative organisms like diplococci, which are the causing the Neisseria meningitis. It give a gram positive, gram negative diplococci. We do for the cultures. We can go for the bacterial cultures. We can go for the fungal cultures. We can go for the tuberculous cultures. Viral infection usually do not grow on the culture, so cultures are not sent in cases if we are suspecting any viral cause. Okay, PCR is the test which is used to extract the messenger RNA, and it is performed in various diseases like TB and viral. This is the most helpful test in the cases of viral infections. Gene expert test is done for the cases of tuberculous meningitis, and it not only the rapid test to access, because TB culture need 4 to 6 weeks to grow the organism, and gene expert usually give us results in 2 to 3 days. It not only tells that whether the Mycobacterium tuberculosis is present or not. Second, it will give us the resistance for the rifampicin and isoniazid also. So the culture who come to us for the resistance, because one is simple TB and one is MDR, that is multiple drug resistance TB, so result will be delayed. Okay, we have to go for the fungal smears and cultures in cases of fungal diseases. Okay, so what are the indications when we perform the lumbar puncture test to evaluate the cerebrospinal fluid analysis? If we are suspecting any kind of infection, meningitis, either bacterial, viral, or tuberculous, if we are suspecting encephalitis, so both of these are the infections. So similar like any other infection, patient come to us with the fever. Number 1, there is a sinus involvement, so there will be a headache. Sometimes patient can be drowsy. Due to raised ICP, patient can have a vomiting. Due to brain parenchyma involvement, they can have a fit. So diagnosis of meningitis, encephalitis, if we are suspecting, then we go for the lumbar puncture. Inflammatory disorders like multiple sclerosis or the inflammatory disorder of the peripheral nerve, that is Guillain-Barré syndrome, we can again perform the lumbar puncture. Cases of myelitis, that is spinal cord involvement, or in cases of subarachnoid hemorrhage, because subarachnoid hemorrhage is in the subarachnoid space. So whenever we do the lumbar puncture, we will get something that is blood. Okay. Hepatic encephalopathy. This is lumbar puncture in cases is to exclude other causes, not to diagnose hepatic encephalopathy, because in hepatic encephalopathy, lumbar puncture will be normal. In cases of meningeal malignancies, okay, so malignancies which involve the meninges, because CSF gave us more information when the meninges or the nerves are involved, because it is around running between the meninges. If something is purely related, is only in the brain parenchyma, then there are less chances that CSF will give you some finding, because CSF is not going deep into the parenchyma, right? It is on the cortex and between the meninges. So anything which is close to meninges or superficial to the cortex, it will give you more information. Now, however, this is the one indication. Other indication for we have to assess the response to therapy in cases of meningitis. For example, if someone coming to us with a history of meningitis, but history is not very convincing that this is bacterial or tuberculous, because in tuberculous we have a long history, in bacterial we have a history of days. Sometimes patient come to us with a history of 1, 2 or 3 weeks, but we are confused and or the history is not adequate. Then we repeat the CSF analysis after 14 days of therapy for bacterial meningitis. If CSF is clear, means it was most likely bacterial or any other inflammatory disorders. Sometimes we have to administer some drugs intrathecally. Most these are chemotherapeutic drugs or radiologic contrast media. So lumbar puncture is performed in that cases also. So the diagnosis of various diseases which I have listed. Number 2, assessment of response to therapy. Number 3, intrathecal administration of the drugs or radiological contrast media, and to reduce the cerebrospinal. There are cases of increased intracranial pressure. So what we do the CSF puncture. Number 1, we measure the CSF pressures, which are usually high in cases of benign intracranial hypertension, and then we drain the CSF, extra amount of CSF, so that this pressure has been reduced. So these are the mainly indications. What are the contraindications? If you are suspecting any intracranial mass lesion, means if patient has prolonged history of headache and vomiting, and now he come to you with a focal weakness or seizure, then you must think that there is something inside the brain. Intracranial mass lesion means intracranial any tumor, abscess, or malignancy. So in that cases, we do not perform lumbar puncture without prior CT scan brain, because if there is a large mass and we do the CSF puncture, what we do, we reducing the space and suddenly brain herniates. So there is a herniation of the brain. So in cases of intracranial mass lesion, you do not perform lumbar puncture prior CT scan. If CT scan is not showing any pressure effects, then you can do the lumbar puncture safely. Or there's a large mass lesion, then you do not perform the lumbar puncture. If in cases there is a local infection on the site of puncture, that is L2, L3 lumbar space or L3, L4 lumbar space, in that cases you cannot perform, because in case you perform, you will introduce the infection in the subarachnoid space, and this can lead to iatrogenic infections. In that cases, what will you do? You can do the cervical puncture instead of lumbar puncture, or there is a cistern puncture. Cistern means the spaces which are present in the brain. So these are the cisterns. You can do the cisternal puncture, but cisternal puncture is usually not performed nowadays. In cases there is a coagulopathy, means there is person who has a known deficiency of some clotting factor, or who has a thrombocytopenia, means whose platelet counts are less than 20,000, or they are rapidly falling platelet count. In cases of someone with complicated malaria or the dengue or hematological malignancy, you do not perform the lumbar puncture, because if you perform the lumbar puncture, there is a risk of bleeding and hematoma formation. So if there is dying necessity, you have to correct this by giving them platelet infusions. If you are suspecting any spinal cord lesion, then you do not perform lumbar puncture directly. First, you will do a myelography. This is the test which is look for the assessment of myelo means spinal cord, myelography, and you will look for the structural pathology. If the pathology is significant, you will not perform the lumbar puncture. Okay, so what is, I have already told you, this is the normal CSF analysis, that is opening pressure is less than This is in centimeter. What I have told you, it was in millimeter. So it is easy to remember that if you learn the pressure in millimeter, but centimeter, 5 to 20 centimeter of water, or 180 to 200 millimeter of water, it is clear. No cells or less than 5 cells, but which are lymphocytes, not polymorphs. Okay, and there are no RBCs. Proteins up to 45, glucose is 2/3 of the serum, right? What happened in bacteria and virus? Bacteria are the organisms which has a cell wall, so they consume more sugar, right? And they have cell wall, so they have a more protein. So what happened to them, that in viral pressure, there are mild elevation of pressures of the CSF, but in bacterial the CSF pressures are elevated. Viral, as they do not have a viral outer coat, so the CSF picture is usually clear. But in bacterial infection, they are large, they have a cellulose wall, so they are turbid. Because bacteria produce pus, viral do not produce pus. So some bacterial infection who are complicated, they can give you a turbid or the pussy appearance of the CSF, especially tuberculous one. Now what happened to the cell count? You know, in the virus, the cell count can be up to 1,000, but usually it less than 100 cells. And they are mainly lymphocyte, like any peripheral viral infection. What happened in bacterial infection? Cell count is more than 100, 200, 300, 400, or sometime in cases of brain abscess, it can go into the thousands as well. Like in any peripheral infections, the cell which found in the bacterial infections, there are polymorphs. Okay, polymorph means neutrophils. Okay, in viral and bacterial, there will be no red blood cells in the CSF, but in cases of subarachnoid hemorrhage, because there is a bleeding, you will get a red blood cells. I will tell you in the next slide. Okay, proteins are elevated in viral, mildly elevated, but in bacterial, proteins are highly elevated. So in viral, proteins are usually less than 100. So it is a roughly estimate to remember that WBC count will be less than 100 in viral, and protein count is also less than 100. But in bacteria, cells usually go more than 100, and in proteins, they are also more than 100. And viral consume bacteria. I think this is wrongly written over here by mistake. The bacterial infection, they consume more sugar. Viral consume less. So what happened, that in viral infection, sugar either remain normal or slightly reduced, right? But in bacteria, sugar is much reduced. This should be lesser than the sign, not that this was a mistake over here. Okay, so if you see, this is again the viral bacterial, and this is the subarachnoid hemorrhage. What happened? Again, the pressure in the subarachnoid hemorrhage is elevated. Appearance, it grossly bloody, or the xanthochromia, means it gives you a yellow color due to heme formation. Proteins are elevated. Glucose is normal because there is no organism. Gram stain again will be normal, but it is positive in bacterial culture. I have already told you that we perform gram stain studies on cases of bacterial infections. WBC count may be slightly increased in subarachnoid hemorrhage due to red blood cells. Otherwise, there is no increase in CSF count. Okay, so our next investigation is X-ray. We perform X-ray skull and X-ray spine. X-ray skulls are used to look for the major abnormalities like any fracture, hyperostosis. Hyperostosis means overgrowth of the bone, and it's usually occur in the cases of meningiomas. Bone erosions due to skull wall tumor, or there is a lytic lesion in cases of multiple myeloma. Sometimes we can see, but it's very rare, that we can see the pineal gland shift from the midline. Pineal gland is the small gland in the brain which calcify, because on X-ray we can see only those structures who are calcified. We cannot see the brain parenchyma. So if something which is calcified in the central normally and it's displaced to the other side, we must think that there is some space occupying lesions. or we can see any other abnormal calcifications such as tumor, meningiomas, oligodendroglioma, craniopharyngioma. These all are the tumors who calcify. Those tumors who do not calcify, we are unable to see them X-ray skull. Okay, and we can sometimes see any intracranial aneurysm who are calcified. For X-ray spine is used to see the vertebral fracture, misalignment, or the erosions. So this is the X-ray skull. What we are seeing, this white thing, this all is the bone. And why we are able to see? Because it is a mineralized, it has a calcium content. We cannot see the brain in this patient because brain is not calcified. So on X-ray skull lateral view, we can see there is a shadow which is brighter as a skull. So means this is also something calcified. When this patient was further evaluated and his CT scan, this is CT MRI was performed, you can see there is a midline calcified lesion. So this was a meningioma in this patient, which was picked up on the X-ray skull, and this patient was presented with a history of headache and fits. Anything which irritate the brain parenchyma, whether it is a brain tumor, it is a blood, it is any tuberculoma or all, it can cause seizure activity. Okay, this is the X-ray skull. If you can see, this is the, from here front to back we are going. So there is a smooth outline, but there is a sudden dip. See, and this again. So this patient presented with a history of trauma and unconsciousness. When we see there was a dip, this was a depressed fracture. You know, fracture has various types. Sometimes there are hairline fractures, and sometimes are depressed. So here bone is not present. Bone is not present, is replaced by the air. So fracture, whether it is a hairline or the depressed, it will show you that black kind of lesion instead of that white normal bone. So we proceed with the CT scan in this patient. Okay, now what other investigation? This is next investigation is CT brain. Okay, we perform the cranial CTs, and we perform the spinal CTs as well. Spinal CTs basically are 3D CTs, and we look for these are mainly done by the neurosurgeons, and the spinal CTs they are performed to look for any fracture, any misalignment, or any reconstructive surgery. So they need a 3D CTs. Now we perform the cranial CTs. Cranial CTs means brain CTs. They can be plain or contrast. Why contrast is used? Contrast is used for any kind of infection, any inflammation. These all thing enhances on contrast studies. So what we do, why we perform the CT scan in acute neurological lesion in the brain and head in cases of skull and spinal cord fracture, you can get CT because CT is more good. CT is more good to visualize brain part, bony part of the cranium. And it shows the brain parenchyma as well. But if you want to go into the soft tissue detail or the brain parenchymal detail, you need MRI brain. So CT brain in cases of skull or spinal fracture, we go. In cases of any neurological emergencies like intracerebral hemorrhage, it can be extradural hematoma, it can be subdural hematoma, or it can be intracerebral or interparenchymal hematoma. You can see this on the CT scan brain. Sometime what happened, there is an inflammation of the brain. So brain is seem edematous, whether it is due to trauma or this is due to any inflammation or any infection of the brain. You can visualize the brain edema, how the sulci gyri are not visualized properly. Sometimes mass lesion, tumors, or brain abscess, you can find them on the CT brain as well. Hydrocephalus is usually visualized. Stroke, we can easily differentiate between hemorrhage and infarction because infarctions are usually not picked up on the CT scan brain, and CT scan brain looks normal till 12 hours after the infarction. But intracerebral hemorrhage or any kind of hemorrhage picked up within 5 minutes after the event. So in cases of infarction, that is cerebrovascular accident, ischemic cerebrovascular CT can be normal. So we can differentiate with the help of CT that this is ischemic stroke or hemorrhagic stroke before LP or before giving any treatment for the stroke, that is tissue plasminogen activator. Because in CT scan brain, if you perform and you will find a hemorrhage, this is a contraindication for tissue plasminogen activator. So this is a CT scan brain. I have bought these pictures. This is a plain CT. You know, this is the bone. This is the white bone. This is whole is a parenchyma, frontal lobe, parietal lobe, occipital lobe, right? This thing is the CSF, ventricles, lateral ventricles. This is the contrast studies. How contrast studies, I will tell you. So, you know, on this CT scan, we see this is the absolutely normal CT scan. You have to compare this with this. Okay. So this is a normal CT scan brain, but there is slight one pathology that ventricles are very slit-like, and like here you can see these are sulci and gyri. You can visualize, but the sulci and gyri are not visualized in this CT scan, and the ventricles are not in the normal size, but they are slit-like. So this is the CT scan brain which consistent with cerebral edema, number one. Number two, now when you compare this, you can see the sulci gyri on this sides are good. Okay, fine. But there is something abnormal there here. What? You can see this is hypo-intense. Hypo means the signals which are darker than the brain parenchyma, and the hyper means the signals which are same like the bone. So there is some hypo-intense signal. Hypotense signal on this part. This is frontal lobe, this is frontoparietal area, and in between there is some signal which is same like this bone. So this is calcified lesion, and if you can see, there is overgrowth of the bone. This is the hyperostosis. Okay, when we do give the contrast, you can see this is the white thing which is coming in the fissures. This is contrast, so this thing enhances, okay, on the contrast. So this is diffusely enhancing with central calcification, hyperostosis. This is a meningioma. Okay, this is meningioma in this patient. And forget about this. This is MRI brain. Now, what is this? This is slit-like ventricles, and these are dilated ventricles. These are not normal. Okay, these ventricles are larger than the size of normal ventricle. These are the anterior horn of the lateral ventricle. These are the posterior horn. This is the third ventricle. These all are very dilated. So this is a CT scan of hydrocephalus. Okay. Sorry. And one thing you can see, there is distortion of anatomy as well. These ventricles are not visualized, means these are compressed, and these are shifted towards the right side. So there is a midline shift. This is the midline shift. This is midline shift. This is midline, and this is so this is called as midline shift of mass effect. So you will not perform this lumbar puncture in cases of this kind of CT scan brain, right? Okay, now this is again a CT scan brain of some patient, and you can see this is a contrast, because this is white thing is which is going inside. This is all contrast. You can see this is a large mass which is enhancing on the contrast. So this is again a large tumor. Okay, and how will the stroke look like? This is how the stroke give you a hypodense signal on the CT scan after 12 hours, and this is how the hemorrhage. This is the intraparenchymal hemorrhage with the ventricle. It is also spilling into the ventricle. So this is a ventricular extension, right? So this is hypodense signal involving the frontal and parietal areas on the right side. This is left side, and this is the right side. Okay, CT is always opposite to our body, and this is the hemorrhage. Now this is again normal brain parenchyma. Something is along with the skull on the both side. See, so this is a banana shape or the crescent shape. This is subdural hematoma. Okay, means between the dura space and pia mater. Okay, this is epidural hematoma, biconvex or lemon shape. This is the biconvex shape. This is epidural hematoma, means hemorrhage between the two layers of dura mater. Okay, so this is epidural hematoma. How this is the hemorrhage or hematoma look like, and how the ischemia look like, yeah, infarction look like. This is subarachnoid hemorrhage. This is an aneurysm, large, which is ruptured, and it lead to the spillage of blood in all the subarachnoid space and the basilar cistern area. So this is how the subarachnoid hemorrhage look like. Okay, so our next investigation is MRI. MRI, what is MRI? MRI is the very advanced form of the neurological investigation, and sometime on CT we are unable to find many things, so we go for the MRI studies. There are various sequences. You don't go into the detail of these sequences. If you want, you can, if you are interested, you can read yourself, but here I'm giving you the name, that is T1, T2 weighted image, flare studies, contrast studies. Again, contrast studies are performed to look for the tumors, AV malformations, infections, meningeal enhancement, and all. This is a DWI image, diffusion weighted image, which is used especially in cases of a stroke, and it is able to pick up stroke within 5 minutes. Okay, this is a SWI image, that is susceptibility weighted image, which is used in cases of hemorrhages. Ischemic stroke, which we are unable to pick up on the CT scan up to 12 hours. CT scan can be normal. With the help of MRI, we can pick the ischemic stroke within 30 minutes when CT brain is completely normal. And with the help of DWI image, that is diffusion weighted image, we can pick up the ischemic stroke within 5 minutes as well. And in cases of intracranial tumor, we are able to pick them with the help of MRI very accurately, because the intraparenchymal tumors, I have already told you, the MRI is good for the soft tissue visualization. So intraparenchymal lesions are very good and accurately picked up by the MRI. CNS infection, whether there is any abscess formation, any tuberculoma formation, any ring enhancing lesions, or herpes simplex encephalitis can give you signals on MRI in temporal lobes. MRI, we do MRA, which is magnetic resonance angiography, with the help of MRI, and it will help you in the diagnosis of arteriovenous malformations. Sometimes we have strokes which are venous strokes, which are called as venous sinus thrombosis. If you can recall your neuroanatomy, we have a superior sagittal sinus, we have inferior sagittal sinus, we have transverse, sigmoid sinus, and all. So when there is a thrombosis in those sinuses, with the help of MRI, special sequence which is called as MRV, that is magnetic resonance venography, which is for vein. For arteries, we do MRA, that is magnetic resonance angiography. So we can pick up AV malformation as well as venous sinus abnormalities. Some cranial abnormalities which are not being picked up by CT because posterior fossa and upper part of the brainstem, that is both cerebral hemispheres, posterior fossa, medulla, and all, it is not visualized on the CT. So for looking for the posterior fossa pathology or craniospinal abnormalities such as island carry malformation, syringomyelia, we perform the MRI. Now we perform the MRI spine as well, and MRI cervical spine is localized, performed separately for the cervical lesion, dorsal region, and the lumbar region. So any kind of abnormalities, yes, syringomyelia, that is abnormal cavity formation in the spinal cord, myelitis, or spinal cord tumors, these all can be picked very accurately on MRI, but these are not being picked up by CT spinal cord, right? Because CT spinal cord focused or able to visualize or give us the images of the bone only, but not on the spinal cord. So for the spinal cord pathologies, we go for the MRI, not for the CTs. Okay, any kind of disc prolapse, or spinal cord stenosis, or any kind of myelopathy, that is spinal cord pathology, we perform the MRI studies. Okay, so this is MRI brain. You can see there is a hypointense signal in the left parietal areas, frontoparietal area, which is compressing this ventricle anterior horn, and it is causing the midline shift. When we give the contrast on that patient, this is again diffusely enhancing, and it is giving you large tumor, which is a meningioma. The difference between the CT and brain, you can see that this white thing is not the bone, but in CT this is your aponeurosis. This inner lighter hypodense area, this is the skull. This below this white line, this is your skull, and this is your brain parenchyma. You can see this is outer side is the gray, inside is the white, And if you can carefully see, you can see this is the area of internal capsule. So gray matter, white matter, you can easily visualize the gray and white matter. So this is a MRI. This is another MRI of the patient who come to us with a history of weight loss, fever, headache, vomitings, and alter level of consciousness. With the history of TB contact was positive when we performed the CT scan, MRI, brain contrast studies, because I have told you for infections, for any tumors, we perform the contrast. This is the plane, this is the contrast. So you can see there are multiple ring enhancing lesions in various area in the frontal cortex, sorry, in the frontal cortex, in occipital areas and all, in the pons. This is the sagittal view, this is the pons, in the cerebellum. So these were multiple tuberculomas. Okay, ring enhancing lesion can be due to multiple sclerosis. These can be due to sarcoidosis. Ring enhancing lesions can be due to multiple metastatic lesions. These can be due to cysticercosis. So there are various etiologies. We must keep into the mind, and we have to correlate with the history and clinical examination. Okay, so this is MRI in cases of stroke. Okay, this is the T2 weighted image. If you can see, the T2 weighted image is normal in this patient. But when we perform the DWI, as I have told you, the DWI image, that is diffusion weighted image, is the image earliest to pick stroke. Though we perform the MRI, but it was unable to pick the any abnormality except this subtle if you look carefully. But same lesion giving us the diffusion restriction, hyperintense signal, and after a few hours, this intensity appear and this restriction increases. This is whole middle cerebral artery infarction. Now after 6 to 7 hours, or this is at the 7th day, you can see this is a 7th day. At 24 hours, this is visualized, but this is very marked. So you can see with the passage of time, on T2 weighted image, signals become more and more apparent. On DWI, they are apparent in very early phase, but after 7 days, they start normalizing. This is again the T2 weighted image of the patient. If you can see carefully, you can find only small hyperintensity, but this intensity is not visualized, but this is the DWI image. And this DWI image normalizes, is showing the diffusion restriction in early stroke. Okay, so why MRI is better than CT? Because in cases of the diagnosis of diseases related to soft tissue, for example, brain parenchyma, MRI is able to visualize, give us more detail. CT is mainly focusing on the bone only. In cases of spinal cord pathology, CT do not give us any information, but MRI give us lots of information. Posterior fossa is not visualized on the CT scan properly. For example, the cerebellum and the brainstem tumor, but MRI gave us a detail. Spinal cord pathologies, again, I have already told you, we go for the MRI, not for the CT. In cases of
जी डॉक्टर मिराज, मैम आपकी आवाज नहीं आ रही।
we will quickly go through few important investigation. These are the nerve conduction studies and electromyography. These are used in cases of neuropathy. We check for the nerves. In cases of muscle disease, we check for the EMG. And in cases of myotonias, we go for the electromyography. For cases of the diagnosis of neuromuscular junction disorders like myasthenia gravis, Lambert-Eaton myasthenic syndromes, or snake poisoning or botulinum toxin, we perform again the nerve conduction studies in EMG. These studies help her in the diagnosis of motor neuron disease. You will go into the detail and for the findings in the lecture concerning to these. Okay, in cases of motor neuron disease, that on the lecture you will came to know what are the findings. Cases of myasthenia gravis, you will go into the you will be taught about the findings. Whether the neuropathy can be mononeuropathy, can be polyneuropathy, or when there's a plexus involvement, we can use these nerve conduction studies in EMG to diagnose and exactly localize that where is the problem in the one nerve, in multiple nerve, or in the plexus. Okay, and we have to differentiate between axonal and demyelinating type of neuropathy on the basis of nerve conduction studies as well. And beside this, in some cases we go for the auditory and visual evoked potentials. These are the used in cases of multiple sclerosis. I did not show you the MRI of multiple sclerosis because you will be having a separate lecture on demyelinating diseases. So you will be able to see what are the MRI findings and spinal cord involvement. Auditory and visual evoked potentials are done whenever there is a optic nerve involvement in cases of multiple sclerosis. So there will be a delayed transmission of the impulses. So you will find that abnormality. Muscle biopsy is performed in cases of diseases of muscles or muscular dystrophies. And CPK level, this is the enzyme which is creatine phosphokinase, and it is released from the muscle. So in cases of muscle diseases, it will be elevated and it helps us in localization of our disease diagnosis. Muscle biopsy is performed to look for the muscles histopathology, number one, and we do different enzyme stainings in that so that we can look for the dystrophin gene and genetic testing as well. So these are the main investigation which we looked, and this was my last slide, and thank you for listening. If you have any question, you have a 1 minute, because I think I'm unable to get any I think on chat there is one message. CT contrast can diagnose tumor as well, right? Yes, CT contrast can diagnose tumor as well, and especially meningiomas. Okay. What are the main causes of seizure? Can COVID-19 can lead to encephalopathy? Yes, COVID-19 can cause encephalopathy. It is causing stroke. It is causing Guillain-Barré syndrome and many complications. What is that hypodense area? I think I have already mentioned. What isn't the darker color area hyperdense? No, it is hypodense. Hyper means bright. Okay. Okay. The next question was, please explain the lemon and banana shape of hematomas. Again, it is very difficult. No time, though I have explained very well. Achha, next question was, in a patient with a contraindication for MRI, someone who had an orthopedic procedure with implantation, does CT give adequate knowledge about the brain disease? Okay, this is a good question and practical question. In cases those patient who has orthopedic implant or metallic rod, it depends. If they have metallic rods, because more CTs machines, MRI machines are coming, they are more compatible. So what they do a metallic sheet covering of that area, and they then send the patient into the MRI. So those MRI machines who are compatible with these implants and they have a facility to cover that metallic implant. For example, we have to go for the MRI brain and someone has some rod in the leg. This is far away from the brain. We cover that area with a metallic shield and we send the patient for MRI. Okay, CT contrast can diagnose tumor as well, right? Yes, it can diagnose. Can you please repeat the slide of T2 weighted images and DWI? I cannot write, I'm writing short of time. In a patient with a contraindication MRI, and this is, I think this has already been done and I have answered. Okay, that was repeat. Okay, so I have answered that. I think people get adequate answers of your questions. Though I would like to do extend my lectures, but I'm short of time. There is many other investigation. I can just tell you the names. because there is a lot of detail and 1 hour is insufficient. There is a lot and lot of advanced studies has been going on the neurology. There are PET scans, PET scans, and many more studies which are coming. So investigations, but they have their own detail, and I have limitation of time and your study level as well, because final level you don't need. Okay जी, thank you Moha. Okay जी, thank you so much. Okay जी, Allah Hafiz.
Okay, madam. Take care. Allah Hafiz.
Okay जी.